If you are experiencing a moderate pericardial effusion, you may notice fluid accumulating around your heart. It will appear as an anechoic, or fluid-filled, space between the visceral and parietal pericardium surrounding the entire heart. In this condition, you may experience chamber compression, with right atrial collapse, visible in late diastole, and right ventricular collapse, crucial for diagnosing tamponade physiology. Another phenomenon you may notice is the swinging heart, where your heart appears to move within the fluid, more commonly seen in larger effusions. Doppler findings may also show respiratory variations in mitral and tricuspid inflow velocities, suggesting hemodynamic compromise. When identifying a moderate effusion, the anechoic space measures between 10 to 20 millimeters and is circumferential, surrounding the heart. It is important to differentiate pericardial effusion from pleural effusion, as they have different anatomical locations and respiratory movements. The anatomic locations differ, with pericardial effusion fluid confined within the pericardium, anterior to the descending aorta, while pleural effusion fluid is located posterior and lateral to the heart, extending behind the descending aorta. Additionally, the positioning with respect to the diaphragm is distinct, with pericardial effusion being anterior to the diaphragm in continuity with the heart, whereas pleural effusion is separated from the heart by the diaphragm, appearing more posterior or lateral. Lastly, the effusion behavior during breathing differs, with pericardial effusion remaining stable and not shifting with respiration, while pleural effusion may shift or change shape with breathing. For imaging, views such as subcostal, parasternal long axis, parasternal short axis, and apical four-chamber views are essential for diagnosing and differentiating a moderate pericardial effusion, guiding appropriate management, particularly in cases with potential tamponade